So again, the usual disclaimer, this is an OPD series. This is not a in-depth analysis of any given condition. So the idea behind this series is just to give you a good overview of the condition so that you know how to handle the patients when you are seeing them in your OPD, and you are able to make a good clinical diagnosis. All of these diagnoses and differential diagnoses are very nicely covered in the Conceptual app. I remember Dr. Ravinder Dimri has taken several lectures. There are lectures in the pediatric elbow as well. So for this talk, I have chosen elbow pain in adults. It is a very common upper extremity condition coming to us in the OPD. And we need to probably look beyond the tennis elbow when we are seeing patients with elbow pain. And I hope this particular lecture will make things a bit clearer. So when it comes to the elbow joint, like any joint, particularly the elbow, it is always useful to subdivide the elbow into its 4 anatomical zones: the medial, lateral, anterior, and the posterior sides. Of course, there are conditions like synovitis due to rheumatoid arthritis, or maybe osteoarthritis, or other inflammatory spondyloarthritis, or even tuberculosis, where you have the involvement of the entire elbow. But you'll find that most diseases of the elbow will present to you in one of these anatomical zones. And I am referring to non-traumatic conditions here. Of course, sequelae of elbow trauma, of fractures and dislocations are totally different and probably beyond the scope of this particular talk. So now coming to first the medial side. Now, when you look at the medial side of the elbow, the commonest condition that you are likely to see is medial epicondylitis. And medial epicondylitis is the second commonest tendinopathy of the upper extremity. The commonest, of course, being lateral epicondylitis, also known as the tennis elbow. So medial epicondylitis is the commonest. And again, if you review your anatomy, you'll find that almost anything that lies on the medial side of the elbow, like the ulnar nerve passing through the cubital tunnel, the ulnar collateral ligament, the anterior bundle of the ulnar collateral ligament, all these can be contributors to pain on the medial side of the elbow. So you have, as a differential diagnosis, the cubital tunnel syndrome, you have ulnar neuritis, the insufficiency of ulnar collateral ligament. Now remember that after Neeraj Chopra won the gold medal for us in the Olympics, javelin as a sport has become very, very popular. And I see a lot of young kids coming with medial elbow pain, and UCL insufficiency is something that you must at least be able to diagnose clinically. Now, medial epicondylitis is also known as a golfer's elbow. Generally, the commonly affected muscles are the flexor carpi radialis and the pronator teres. The most sensitive test is pain on resisted pronation. Why? Because pronator teres is commonly affected. There is also a point tenderness 5 to 10 millimeters anterior and distal to the medial epicondyle. And in this manner, it is a little similar to lateral epicondylitis. And lateral epicondylitis also, the point of maximal tenderness is 5 millimeters anterior and distal to the lateral epicondyle. You can also elicit pain with resisted wrist flexion, what is known as a reverse Cosen's test. So these are simple OPD pointers which point you towards medial epicondylitis. The thing to remember is pain on resisted pronation, which is something which we generally don't look at. Now, cubital tunnel syndrome, it is the second most common compressive neuropathy of the upper limb after the carpal tunnel syndrome. It is expected to cause a fair amount of numbness and tingling in the ulnar side of the forearm and hand. And there is motor weakness of muscles which are supplied distal to the elbow by the ulnar nerves. And these are flexor carpi ulnaris, the intrinsics of the hand. The patient may come to you with a varying degree of claw hand. And there's the Wattenberg sign, that is inability to adduct the little finger, or the involuntary abduction of the little finger. And Dr. Ravinder Dimri in one of his talk has very nicely explained why there is a position of abduction with ulnar nerve weakness. That is because of the vector of the extensor digiti minimi. Positive tunnel sign is something which you are likely to find in any compressive neuropathy. In the cubital tunnel syndrome also, you find a positive tunnel sign. And one thing to check for, especially in ulnar neuritis, is the ulnar nerve subluxing on elbow range of movements. So that is something which could be a reason for medial sided elbow pain. Sometimes the patient is not having pain at the elbow, the pain is passing through the elbow, and the pain which passes through the elbow comes from the cervical spine. So remember to examine the neck as well. Now coming to ulnar collateral ligament insufficiency, it is commonly suspected in throwing athletes, particularly with javelin throw. It is increasing in popularity as a sport amongst youngsters. Now, there are two tests which are routinely done for ulnar collateral ligament insufficiency. One is known as a moving valgus stress test, and the other is known as a milking maneuver. So essentially, in a moving valgus stress, the shoulder is in a position of 90 degrees of abduction and external rotation. You give a valgus stress at the elbow and then you bend and extend the elbow. You will note pain between the arc of 70 to 120 degrees of elbow flexion. An easier test to do is what is called a milking maneuver. Essentially, you pull at the thumb with the elbow bent to 90 degrees. So when you pull at the thumb, you're essentially imparting a valgus strain along the elbow and you feel along the course of the ulnar collateral ligament. This is a very sensitive test and it is very easily elicited in the OPD. Sometimes the mere act of pulling the thumb with the elbow at 90 is enough for the patient to tell you that he or she is feeling a lot of pain along the medial side of the elbow. It is only very occasionally that you need to feel along the course of the ulnar collateral ligament.